right, and I believe it was slide 15, is that correct?
Let me see where we're at. Yes, okay, so I can't remember if we talked about this slide or not, but just to start, this is a two-part series. So this is kind of the second part of, an introduction to LVAD and patient management. One of the things I think we kind of ended on this, but we can start here is a good point, arrhythmia management with LVAD patients. So basically with these patients, BLS and ACLS protocol is perfectly acceptable, amio, lidocaine, cardioversion, defibrillation. Definitely not a problem. Just we don't typically do chest compressions on these patients. If the pump is on and running, you see the green circle of life right there on top of the controller. You listen to the patient's chest, you hear the VAD hum, you know that the pump is circulating blood. So really you're not going to do compressions with these patients. If one of these patients presents to your clinic, to the ER, to an outpatient hospital, big thing is give us a call. We have a VAD coordinator on call. You can always call the Mars line to talk to the attending on call, and we can always guide you through taking care of these patients. Next slide. So just the basics on just the overview of the design. I won't spend too much time on this. The HeartMate 3 is the newest pump on the market that we've been primarily implanting here at WVU Medicine. It became available about a year and a half ago, almost 2 years ago, to be implanted for destination therapy or long-term use. But it is a fully magnetically levitated pump. And basically it is designed, the pump's designed to kind of prevent blood trauma. The HeartMate 2 was pretty accustomed to developing pump thrombosis and clots in the pump. So the big redesign of this pump was to make it more hemocompatible to decrease the risk of pump thrombosis. And actually the 2-year trial studies from Momentum came out, and the pump thrombosis rate in the HeartMate 3 is less than 1%. The HeartMate 2, some centers have pump thrombosis rates up to 20%. So it does provide the same range of support, 2.5 to 10 liters per minute. It is a little bit an easier design to implant from a surgical standpoint. The controllers for the 2s and the 3s are very, very similar in nature. The alarms are very similar. So as these patients come in, management of these patients and their alarms are very similar to what the numbers mean. Speed's a little bit different. HVAD is another pump on the market. It is definitely different than the HeartMate 2 and HeartMate 3 pump. We do not at WVU Medicine, we don't implant the HVAD pumps, and we don't have our staff trained to manage care of the HVAD pumps. So therefore, if an outside facility VAD presents with an HVAD, our emergency department is trained to send them to their implanting hospital. Next slide. And just a little bit more of the components. The system controller, very similar to the 2 and the 3. The color scheme's a little bit different. And the HeartMate 3 says HeartMate 3, HeartMate 2 says HeartMate 2. The external pieces from the controller out, in terms of batteries and the system components that we use for the HeartMate 2 and 3 is exactly the same. You cannot plug a HeartMate 3 LVAD into a HeartMate 2 controller and vice versa. And another design that they did with this HeartMate 3, which makes it a little bit nicer for patients, so they did a modular driveline. So therefore, if the driveline over time becomes worn down or the wires, fray or break down inside, you have this modular piece to the driveline that you can in clinic could disconnect and reconnect a new piece. However, I had a patient that cut part of his driveline during a dressing change, and he cut above where you could disconnect the driveline and reconnect a new piece. He ended up, which would in turn been a pump exchange. He actually got listed for transplant, but that becomes a bigger problem when they have a cut in the driveline that's further up than the modular piece. So you have to always tell patients that's your lifeline. If there's a cut, a twist, a break, a lot of times that could mean a complete pump exchange to fix the problem. Next slide. And this just goes a little bit, I think I already kind of talked about this, of how the pump's a little bit smaller. It is intrapericardial placement. The HeartMate 2 is more, they have to build a pocket in the intra-abdominal cavity. It is a larger pump. This is a lot smaller, but the design's the same. It's the LV, there's a open heart surgery core the LV, put the inflow cannula into the LV, and then tie the outflow graft into the ascending aorta. The heart's still in there, the failing heart, and this is an assist device. It's just assisting the heart and pulling blood from the LV and putting it into the aorta. And then there is the external components of the driveline exit site, the pocket controller, and the 2 batteries, which we talked about last week. Big risk of infection at the driveline exit site. One thing with this HeartMate 3 that is kind of that I find the most interesting is what they've been able to do with this generation of a pump is the controls of the pump. The computer is actually stored inside the pump in the patient's body, whereas the HeartMate 2 and the HVAD, the controls are in the external components of the controller. So basically on the HeartMate 3, all the controller is doing is providing power to the pump. So basically the R&D of Medtronic and Abbott are in the process of finding out how to get power into the body and then looking at a fully implantable heart pump. So next slide. So here's just the 2-year statistics for the HeartMate 3, which we talked about, that less than 1% suspected pump thrombosis rate. That's probably the big winner for us. It means the most to us because, as our program's only been we're only 2.5 years into our program, and probably a year in, we replaced a HeartMate 2 pump for pump thrombosis, and we had suspected pump thrombosis in 2 other HeartMate 2 patients. So it was a pretty big problem for these patients. Next slide. And this shows you how the 2-year survival is compared to HeartMate 3 transplant, the HeartMate 2, and then the first HeartMate XE. And then if you look there, the thing I find is the optimal medical management at 41% from 2017. So definitely see where the LVADs and transplant are definitely well above that at 2-year survival. Next slide. So this shows this slide. It's kind of busy. It's not really my favorite slide, but just to talk a little bit on it, this is really important to me because this shows these patients that get LVADs. I survey them at certain intervals, pre-LVAD, 1 month post, 3 months, 6 months, 12 months, and every 6 months I survey them basically with the standard quality of life forms. And basically it asks them, how is your quality of life overall since, the LVAD? And really what you want to see is there's no sense of putting an LVAD in somebody if you don't improve their quality of life and make them live longer. Like, it's kind of a moot point. So one of the things is, yes, we figured out we've been able to make them live longer, but have we truly improved their quality of life? And to be able to see that we've done that and see the things that they can now do that they couldn't do pre-VAD is truly amazing. I mean, I don't know if I said this last time, and I'll say it again because I say it all the time, but one of the most touching things my patient told me was he came into clinic. He was just, I don't know if he was maybe 6 months out of VAD. And he told me, he said, "Hey, Monica, guess what I did this weekend?" I said, "What's that?" He said, "I played tennis with my daughter." He said, "I haven't played tennis with my daughter in probably 8 years." And he said, "I played for an hour." He said, "I broke a sweat." And he was able to do that. And that just really goes to show you that you do improve these patients' functional status and quality of life. Next slide. A little bit more on the Momentum 3 trial, if you guys are interested in that. I do like evidence-based and research papers and journal articles. This is a good trial. This is what kind of brought the HeartMate 3 out, but I'm not going to harp on it. I'm going to go next slide. This slide, and it's kind of busy too, but one of the big things with one of the big things I want to point out on this, that we've not really been seeing a difference in with the newer pump with this HeartMate 3 is we've not seen a reduction in bleeding. These patients still bleed. And I think I touched on this the first time, but it's worth talking about again. There's several reasons these patients bleed. One, continual flow device. So you're getting forward flow, continual flow. You're not getting pulsatile flow like lub dub of the heart. So AV malformations. Patients develop acquired von Willebrand factor. And then on top of that, and platelet dysfunction from the VAD itself, we put these patients on blood thinners. They're always on Coumadin. They're usually almost always on aspirin. And then sometimes we even see them on something else like, Brilinta or Plavix, or Persantine's kind of a big one, more studied in VADs. It's an older antiplatelet drug. But so you see that happen in these patients. So what we're seeing trials for now and what the push is to see how much anticoagulation, or is anticoagulation required in these HeartMate 3 patients? Is that something we can back off because they do have that decreased, really almost none pump thrombosis risk. So is this something, and backing off the anticoagulation, is that going to help your bleeding? These patients do still have strokes. Unfortunately, they have head bleeds. They end up with thromboemboli. I think it's like right around 10%, a little less than 10% stroke in this patient population. So next slide. So just a big key point on these patients that I always like to push home to people, especially if they, they land in your clinic. They live in the community. They're going to be in your clinic. They're going to be in your ERs. They're going to be in your hospitals. They have to have other procedures, and they have to have primary care and other doctors take care of them. But the big thing is, you're not going to get a typical blood pressure there. Continual flow devices, even though the HeartMate 3 does have this built-in artificial pulse, it is an artificial pulse. A lot of times these patients are still, only about 1 to 3% of them are pulsatile, but these patients don't have a pulse. You're not usually going to obtain a standard blood pressure with the systolic and diastolic. So you have to use a Doppler to obtain their blood pressure. You can place them on a monitor. The EKG rhythm you see is usually what you get. It doesn't technically interfere with their heart rhythm, but you will see some, with the HeartMate 3s, it does cause a lot of artifact when you're doing a 12 lead on these patients. I still will never forget the first time the EKG tech came right after surgery for the HeartMate 3 patient, the first implant we did. And I think I don't know how much paper he wasted printing and trying to get the artifact to clear, and it doesn't. On those 12 leads, it doesn't. One thing you can do for the monitors in the room with your 5 leads is if you get strategic about where to place the stickers, the bedside staff's really great at it. They can get the interference off the monitor, but the rhythm is what you see. And if you remember from before, if you see these patients in VFib, and talking to you, that's absolutely normal. They're supported, they're getting forward flow, but they're actually could be in VFib. Pulse ox could give you a heart rate, and they should give you an SpO2. I've been having a difficult time in my HeartMate 3 patients getting a good read on a pulse ox with these patients, and I don't know if it's some interference. I've been reaching out to the VAD community with that built-in artificial pulse or what, but I'm working on, like, we've been using little ear probes and pediatric probes and everything. Big thing, no MRIs with these patients. CT scans, x-rays are totally okay. No wanding, no metal detectors, no swimming. They cannot be submerged in water. We do let them bathe, not bathe. We let them shower after things have healed up, but they have some protective equipment to help them and some pretty specific instructions of how to shower so that they, don't have water dwelling in their driveline exit site. CPR is not something that we do on these patients because you could dislodge the cannula. And, caregiver and the support person, this has been really, really hard with COVID. Is the big thing with VAD patients is they go home with this equipment and living in the community with an LVAD, and they always, one of the big criteria to get an LVAD is having a caregiver or support person to help take care of you, and we always make them have a primary and a backup, and they're very involved in the, when we implant the pump before and after, and doing a lot of patient education. So being able to navigate without being able to have visitors in the hospital has been pretty difficult. Done a lot of Zoom education, and the day of discharge becomes a very long, exhausting day trying to get these people ready and to go home and manage care of this. But once all this ends and, caregivers are around and patients are coming in with their family, they usually almost always bring their caregiver with them. They're a good support person. They know by the 6-month mark, these guys know exactly how to take care of these pumps. Like, they're the pros. They're teaching other people. Like, they're really good at it. So knowing that the patient and the support person are total resources to you all at any time. Next slide. So patient identification for advanced heart failure therapy. So this is kind of, this is a lot of stuff, and a lot of my doctors do a pretty long and good presentation on this, but I like to always touch base on it whenever I do an LVAD presentation, just to make sure that we're getting timely referrals and being able to help people. Sometimes these patients, I'm not saying they do come in cardiogenic shock and they're in pretty bad shape, and we've been able to help some of those, but a lot of patients end up, going to hospice, and, you sit there and think, and of course, hindsight's always 20/20, but you look to say, man, if I'd have got this patient, a month sooner, if I would have, seen them then or this, like, maybe we could have done something for advanced therapy with these patients to see if they're an advanced therapy candidate. So next slide. So just making sure, with heart failure, it's multifactorial. This is the big thing. This is every patient? Quit smoking, weight management. We make sure they track their fluid intake, avoid alcohol. We do a lot of medications, maximum optimal medical management on these patients. We have an inpatient heart failure nurse that basically, we have one inpatient outpatient, but the inpatient heart failure nurse basically sees every heart failure patient that comes in this hospital. If a patient gets admitted to an off service and has a heart failure diagnosis, it's cued into our inpatient heart failure nurse to look at things and and, check the boxes to make sure they're on optimal medical management, and talk to the providers to say, hey, they're not on this, but, you didn't really document why, is there a reason, and making sure that we're, hitting all that criteria. And then, of course, you have your implantable devices and stuff that, you see a lot, your EP folks with your ICDs and CRTs. We have a good relationship with our EP department here. Of course, we are huge in pulmonary artery and Swan-Ganz catheters. It was great. When I was a bedside nurse, we had them all the time on our open hearts, and I loved it. And then, like, the tables turned a little bit, and nobody was using them. And then when we developed our advanced heart failure team, they came back, and I don't know, I love it. The more numbers I can get on a patient to help manage their care, the better it is for me. But then knowing that we, bypass surgery, heart valve surgery, LVAD and heart transplant. So next slide. So one thing you see a lot with heart failure patients and all the time is you see their NYHA class scale. So it basically tells you, the New York Heart Association classification, and it kind of defines where their heart failure is. Once these patients hit like 3B to 4, then we jump over to an INTERMACS, which INTERMACS is a registry that we use for our mechanically supported patients. And that we take that 3B and 4 classification of heart failure, and we even further define it out. And it's a 1 through 7 classification, with 1 being a patient that presents to you in cardiogenic shock. We do VAD these patients. They don't have the best outcomes. This is not when we like to VAD a patient. 3 to 4 is like the ideal place to VAD a patient. They have the best outcomes, 4 being like the absolute best. But it's hard. It's hard to find these patients. Anybody that manages heart failures know, and I know Mary's on here and could definitely speak to it. It's hard to find the right time when they're not, where they're too well versus being too sick. But knowing that we utilize this, INTERMACS registry to kind of have an idea of when we need to start VADing these patients and where they fall in this. And if you look, I think next slide shows their outcomes based on that INTERMACS. You can go to next slide. Yeah, so outcomes. So ideally, you want to do the INTERMACS on these patients, or you want to VAD them when they're at an INTERMACS 3-4, and these patients do have better outcomes if you can, and you look at that timeline. And ideally, we don't, get that opportunity to VAD the patients when they're, at a 3-4. It's usually, a lot of times it's a 1, but we try the best we can with these patients. So next slide. This is a big, I like this a lot, and this came out from ACC expert consensus. And if you ever heard any of our providers, any of the docs give any type of lecture, you'll see this slide in their lecture. And I've kind of like taken it too, because it really is a great, it's really great for primary care offices, general cardiologists, anybody really, to look at this as they're managing care of these patients or these heart failure patients, to know where's the trigger? When do I need to call the advanced heart failure guys? Like when do I need to get them involved? We'll say whenever, call us, we'll, call the team, put the referral in. But really, they use that I need help acronym, and it kind of goes through, if they have, any of these things happening here, the big thing would be call us, send the referral in. It's pretty easy to get refer a patient here. We have you fax in some stuff. We do some baseline testing before we see them, just to cut down on, making sure that we can treat them to the best of their abilities. And the other thing too is we send the patients back. We don't typically steal them. I mean, once they hit advanced therapies, either transplant or LVAD, we hang on to them from that standpoint, but they still need their primary care doctors. They still need their electrophysiologists. They still need their interventionalists. They may still need those people, but knowing that, we can manage these patients. And I know a lot of the referring or outside doctors, they call a lot of our providers a lot too. So, knowing that we're here to help and help with management. Next slide. So here's just contacts and resources so that you're able to get a hold of us if ever that you would need us. So in the event, the patient lands in your unit, your department, your clinic, wherever they do land, and you're like, oh crap, you have an LVAD, what do we do? And my patients, I think I train them well enough, and they're pretty good enough to know that they have to call me and tell me if they step into an outside facility ER, but that's not always, you have an emergency, you have an emergency, but give us a call. There's a VAD coordinator on call 24/7, 365. It's usually me. 24/7, 360 days. There's 5 days that somebody may cover me, but call me. Like, I keep my phone on me. It's always on me. It's always with me. I also carry a pager. If you call the Mars line, they're able to page me We have an office number. If it's Monday through Friday, you can get to somebody. And then, you can always get a hold of any of our attending physicians by calling the Mars line. If you need to send a direct transfer over to the hospital, or, you need to get a hold of somebody because they're on your unit or whatever, you want to call one of these guys, they'll definitely take a call from you. So don't hesitate to reach out to us. And I think that's all I have. So if you guys have any questions.
Awesome. Thank you so much, Monica. That was excellent. And I'll be sure to include your didactic PowerPoint in the recap email that I send out, so everyone has that information as well. So thank you so much. That was wonderful. I do want to open it up for questions. We did get a question in the chat, so I can start off our questions with that. So it was, how much alcohol are these patients allowed, especially given some saying, quote unquote, a little alcohol a day has heart health benefits?
So in terms of alcohol with VAD patients, if they have a known problem, like if we've determined that they have a history of alcohol abuse, then it's no alcohol. We make them go through treatment and no alcohol. If they want to have the occasional drink once, usually they kind of let them, it's usually a few months after VAD, after we've stabilized INRs and we know they're doing okay. We're not worried about any type of neurological issues or anything happening with them. They may let them have a drink. Maybe I don't think he lets them every day, but usually the doctors will say you could have, maybe a drink a week, and just, 1 to 2, nothing crazy, just because the big thing is INR management with these patients, or, you definitely do not want these patients intoxicated where they can't manage care of themselves. So those are kind of your 2 key points on alcohol abuse and an LVAD.
Awesome. Thank you so much. Were there any other questions out there? I wanted to give the floor to everyone out there.
Yeah, I had one.
Sure.
It's just basically to follow up with the whole alcohol thing, because I think being very clear with patients sometimes helps, and especially if we're using the metric system to measure, maybe not the metric, just that system to measure how many units of alcohol you actually have, might give a rough guide. So if we say 1 to 2, I'm still a little bit like, all right, if a patient asks me how much alcohol can I have, what do I say? Especially given that if we take a look at patients who are over 65, if they have, I believe it's 1 or 2 drinks, they're already being classified as binge drinking. So if a patient is allowed to have 1 or 2 a day, and they have 1 or 2 40 quarts of alcohol, that's not good, So I'm just wondering, is it half a unit, using a unit of?
I wouldn't even say a day. Like they don't even say a day. Like maybe a drink a week, 2 at the most a week. Because you're right. You don't want you don't want them intoxicated. You don't want to interfere with, their ability to manage care. And if you've had an identified problem, that becomes an issue too. I know I had my one patient, he liked to have a beer every once in a while, a couple of times a month he'd have a beer, and he'd let me know. One time he had 2, and I think he completely, he like almost dehydrated himself because he wasn't high on volume anyway. And I think that kind of contributed to a lot of the dehydration with him, and they're pretty open with it. We talk about it because I tell them, like, these patients too are like, before you do anything, you need to talk to us about it. You're ready. You want to travel. We need to know, where are you going? And if you're going to go to Denver, Colorado, let's find the closest VAD center in the event you have a problem. Let's send you a letter to TSA. So they're really good. And a lot of the pre-education and post-education of VAD, we touch base on a lot of these things with them. And, if when you feel that you're ready, my big thing is when you guys feel that you're ready to start doing this activity, tell me, like, what's the activity you enjoy doing? I like walking. My most recent discharge, he wants to walk this certain area in Fairmont that he walks with his wife, and it's about 3 miles. And it's pretty hilly. I'm familiar with the area. So I said, when you feel you're ready for that, I want you to tell me, and we'll talk to the doctors in cardiac rehab and see if that's something you're truly ready for. So I think it's a lot of just keeping a lot of open communication with these patients and spending a lot of time with them, and, making sure that they're truthful and honest with you. And I have some patients that, I have a patient right now that's shooting up fentanyl. Like, it's tough. You have some that the majority of my patients are very open and honest with me. Some of them are very deceitful and you don't know. So yeah, they definitely, you try to tell them you can only do this right here. And they end up doing, kind of whatever they want.
Awesome. Thank you. Let's see. Were there any other questions anyone had out there?
Yeah, I was just going to ask, it kind of goes alongside the alcohol, but if there is anything else that like might be an increased risk to people when or after they've gotten VADs?
Um, another thing, and I don't think I said we advised, I don't think I put this in the slides. One of the big things that's advised against with these patients from the company is static electricity. Big jolts of static electricity can actually cause their pump to restart, which it'll just it actually stops for a brief second and then restarts, which never really posed a huge problem. You would tell the patients you really don't want them to vacuum. It's not recommended that you vacuum, and try to avoid, static electricity, staying moisturized in the winter, static guard and different things like that. But with the HeartMate 3, we actually had a recall back in December, because what they realized is if the patients were hooked up to not their battery power, but to the wall power at their home, which is called, their mobile power unit, if they had a strong surge of static discharge, it could fry that power module and then cause their pump to restart. However, this pump in the HeartMate 3 can't restart without a known power source. It can't restart on the backup battery in the controller itself. So basically, they had a patient, and I don't know where this was kind of what started the recall, folding blankets out of the dryer, hooked up to the power module, a strong static discharge, restarted the pump, fried the mobile power unit, the pump couldn't restart. So they had to the patient was very good, I guess, and mindful, and hurried up and put themselves on backup on the batteries, and the pump restarted without incident. But it definitely required a lot of patient education to the HeartMate 3 patients with the power module. I mean, we advised against it initially and do it in our education, but not to that degree.
Yeah, that is super interesting. Thank you for that. Similarly, are there any, I feel like it, in general, improves the quality of life. Is there any comorbidity or anything that you should look out for that could worsen?
So typically patients, bad outcomes, so LVAD patients on dialysis have really bad outcomes. So typically if patients have, irreversible end organ damage, they're not going to get an LVAD, but in the event they go to LVAD and then end up taking a hit to their kidneys during surgery or post-op management or whatever it happens, and they end up on dialysis, their outcome is usually really poor. They're at higher risk for infection. They just do have really poor outcomes. So that's definitely one of the big, comorbidities with these patients. And we really try, our goal is to not put an LVAD in a patient that has a hemoglobin A1C greater than 8. I think our last 3 VADs had a hemoglobin A1C of somewhere between 10 and 12. That's just the patient population in the state of West Virginia. So you do a ton of management with endocrine and, trying to get their diabetes managed and under control.
Definitely. Thank you so much.
Awesome. We did get another question, and please correct me if I'm asking this wrong, but it was, what quality of life tool is used in the survey?
So I use Kansas City has a quality of life. It's a standard tool we use. It's I think it's like a 5-page survey, and it has part of it, we use the ED5Q, and part of that has also a small, not a huge, but like a little cognitive test with it. It's a time test. If we deem, that the patients have any cognitive dysfunction, we will refer to neuropsych for, cognitive assessment prior to. But it kind of goes through, it's kind of a standard form used amongst a lot of the VAD community. There isn't really, we use that in conjunction with like a psychosocial assessment, but there really isn't a standard form. In 2018, the ISHLT and the ACC and all these, they came up with like a consensus of guidelines to appropriately what they deem as important to monitor in terms of quality of life pre and post VAD, what's important from a psychosocial standpoint, pre and post VAD, to be able to make sure that we're managing care of these patients, not just VAD, just advanced therapies really. They did it internationally, but that's really kind of been the only thing that somebody's had that's standard in terms of what everybody's using nationwide or internationally even. But yeah, the forms we use are pretty common. They're used among a lot of VAD centers, but there really isn't just a standard form that everybody is utilizing.
So what's your response rate with these surveys? I'm kind of curious. Just because if it's like you send out 10 and then 2 respond, then your numbers might be skewed or something. I'm just curious.
What's my response rate? Like,
Yeah.
I do the survey. I give them the surveys in clinic.
Oh, really?
Yeah. So what we do, that's a good question. So we have a follow-up. Their follow-up schedule is determined based on Intermax registry data or STS data that needs to be entered. So we have to enter data at week 1, month 1, like 3, 6, 9, 12. So at those intervals, we see those patients are not in the hospital. We see them in clinic. And during that, and they give me like Intermax gives me like a 30-day window typically, plus and minus, to get this data to them. So that I use that's part of the data that I have to enter into Intermax too, as some type of quality of life assessment. So we utilize that, and I do it in clinic, because you're right. You mail something out, you're not going to get a response rate. COVID's really crushed that for me, because we're doing a lot of telemedicine visits. So I've been having a difficult time obtaining some of those right now. And one of the things that some of the VAD coordinator community has mentioned they were doing is some people said they were mailing it, not getting a response. And some people were just calling patients and going through the assessment with them and just asking them the questions through the assessment so they can at least get some kind of data.
So you said Kansas City Intermax or something, right? Is it anything similar to the Edmonton Symptom Assessment Scale? Because I use that all the time for my patients, and that kind of helps me gather how they're doing over time, and it's been a validated tool. I'm just wondering, is this the same? Have you ever used the?
I've not. Why don't you how about I send you what I use and you send me what you use, and maybe we can collaborate, because I'd really be interested in that. Definitely your input, because if you guys don't know, sorry for everybody else on the line, Charles he does evaluations on my VAD patients. So he's part of our team in terms of, he knows my VAD patients, he does their evaluation. And if we have, issues or concerns, we reach out to him because he's a palliative care specialist, so a physician. So yeah, if you want to send that over, that I would definitely like to look at it, and I'll send you what I use, and then maybe we can collaborate something and,
Yeah, no, for sure. Because the ESAS was developed for cancer patients. I'm just wondering how it would perform for heart failure. But yeah, just shoot me an email and I'll email you back straight away.
Absolutely. Yeah, I'll do that.
Thanks.
Awesome. I love seeing that collaboration. Thank you for all that information. We do have a little over 15 minutes left of this session. Did anyone have any other comments, questions, concerns? I'm going to keep people longer than needed, but we will send out all of Monica's PowerPoints and everything, the part 1 and part 2 from 2 weeks ago as well. So keep an eye out for that in the recap email. I have one quick announcement, and that is our next session is on May 15th, and Janet Jasper is providing our didactic on social determinants of health. So we'll send out reminders for that as well when the time approaches. And if anyone has any other further questions for myself or Monica, please feel free to email me, and I'll make sure to have them addressed and sent back to you. Thank you all so much, and thank you so much, Monica, for these great past month with all of your didactics. So we appreciate your time.
Thank you.
And everyone stay safe. We'll see you next time. Thank you.